In today's video, we're going over evidence-based manual therapy techniques for the knee. So manual therapies can be a nice adjunct in your treatment of patients who have knee pain. The majority of literature we have on manual therapies for knee pain are performed in knee osteoarthritis, but I think you can make an argument to use some of these strategies in other pathologies, particularly in folks who have stiff knees, and also potentially in your post-op patients. Just make sure you're not doing a bunch of weird mobilizations on your patient prior to when they should be doing it. However, you just really have to keep in mind that patient education as well as exercise are going to be your two biggest weapons against these pathologies. So if you want to include some manual therapies, great. But it's also important that you don't only include manual therapies. Make sure you're getting your patient education and exercise as well. But do keep in mind that most of the effects from manual therapies are going to be in the short and medium term. We actually have some high quality research to show there's no difference in long-term function, pain, any of those outcomes when you compare just an exercise program with an exercise program plus manual therapies. So in today's video, we're going to go over some evidence-based manual therapies for your patients that have knee pain so you can be happier and improve those short to medium outcomes. What's going on, guys? My name is Dan from fitnesspainfree.com. I am a physical therapist and a strength coach. We've helped to make thousands of incredible coaches and clinicians through online courses, communities, and mentoring programs. The goal of today's video is to make you 1% better. So in a bunch of included studies that utilize massage as part of their manual therapy regime. And they performed massage to all the muscles around the knee for the most part, with most emphasis on the quadriceps. They use a variety of different techniques, including pressure, stripping, as well as kneading. The first we're going to go over is going to be stripping. Now to perform stripping, you can utilize your thumbs, thumb to thumb pressure, just like this. What I'm going to do is find that kneecap. I'm going to go right above the kneecap. From here, I apply my pressure into the patient and slide up along the muscle all the way up to the hip. Now I can bias either inside, the middle, or the outside of the quad. In the study I'm mentioning, they perform stripping to the quad for 5 total minutes. We can also perform some stripping with the fist. This is actually what I prefer. So essentially I just take my fist. It's going to be right above the kneecap here. I put my pressure down into the muscle, not into the kneecap, into the muscle, then slide all the way up to the hip. We can go right through the center. You can also bias the inside a little bit to the vastus medialis, or we can go more lateral to the vastus lateralis. The next technique you can try is called kneading. And essentially when you're kneading, you can use your thumbs, you can use your fingers, you can use your fists. The idea is you're trying to put some pressure down and perform some circular motions. The other thing you can do is use your finger and your thumb, the web space of your hand, come in right above the kneecap. I can squeeze and lift the skin up a little bit and slide through. Now I can take my other side hand, do the same thing, the top of the thigh. So I'm squeezing the thigh, I'm picking up, and I'm sliding through the muscle. So I'm kneading back and forth through the entire quad, just like so. The last strategy you can try is going to be ischemic pressure. So essentially, as I'm gliding through my patient's quad, if I hit a spot where the patient says, ooh, that feels tender, that feels related to my pain, what I can do is I can take my thumbs or I can take my fingers. I essentially will go over that one spot where this knot, or whatever you want to call it, this tightness in the muscle feels relevant to the patient's pain, and sink some pressure into it, and just basically hold this for about 60 seconds, or until I feel that muscle relaxing underneath my fingers. We also want to perform some massage of the hamstring muscles as well. We can use our pressure, our stripping, our kneading. I'm just going to show you the stripping because I think that's probably the easiest one to show. So essentially I'm taking my fist, going right above the joint line, I'm sinking into the hamstring muscles, I'm sliding all the way up from the knee to the back of the hip, just like so. We also have some papers that show working the gastroc can be helpful for folks who have knee osteoarthritis. This one's pretty simple. Again, I'm going to take my fist, I'm going to press the start of the gastroc, and just press up all the way to the back side of the knee. Now we can probably go all the way down towards Achilles and do a full stroke through the entire calf complex, but in these studies they did say to focus mainly on the gastroc, which obviously the bulk of that muscle is going to be about midway up the calf to the knee. We'll also want to include the adductors. We have some research to show that working the adductors is helpful for folks with knee OA. And to work the adductors, basically we have our patient here, Johnny, on his back. Knee is bent to about 90. I'll take the towel and just put it in the shorts here so I don't get a bunch of lotion on the pants. And from here, I take my fist. I'm going to start on the inside of the knee, put some pressure down, and then press all the way up into the inner thigh region, just like so. So pressure down and going all the way up to the inner thigh. Patient can relax their leg up against my legs. They don't have to hold it in place. Usually this is nice and comfortable for the patient.
Excusez-moi, but I've got something pretty juicy for you. Boom! It's an evidence-based guide to knee osteoarthritis. Uncle Arthur comes for all of us over the course of time, and for your patients, it's no different. But if you've got this cheat sheet, then you'll be ready. Let's face it, nobody has time to stay on top of all the papers coming out on a regular basis and make you a really good coach and clinician. Luckily, you have psychopaths like me who love reading through this stuff, summarizing it, and putting it into a nice little cheat sheet. And my promise to you is I'm going to catch you up on the latest research in under 10 minutes. We go over prevalence, weight loss, risk factors, whether or not competing in a sport increases rates of osteoarthritis, and whether or not strength training slows down the rate of arthritis. We go over pathophysiology, clinical presentation, diagnosis, rehabilitation, and management. Best of all, this thing is 100% free. I'll leave a link in the description below. Go ahead and click on that and get up to date on your favorite knee injury, good old arthritis. Now, back to your learning.
Next, we're gonna go over some joint mobilizations. Before we do, I wanna go over arthrokinematics a little bit. So here's my knee joint right here. So I can extend at the knee, I can flex at the knee. And when I do this, there's going to be a roll and a glide of the joint. So when I am extending my knee here, the tibia is actually translating anteriorly. And I'm also going into some slight tibial external rotation. So if I'm trying to improve extension range of motion, I should be working on tibial anterior glide as well as tibial external rotation. When I go into knee flexion or knee bending, the opposite occurs. So essentially when I bend my knee or flex my knee, I have tibial posterior translation as well as tibial internal rotation. And the mobilizations we're about to go over follow these arthrokinematics. Next, we have a mobilization with movement popularized by Mulligan, invented by Mulligan. If you guys want to learn more, definitely check out his courses. I'm going to take a mobilization belt. This goes around my hips and it goes around the upper portion of the lower leg right above the joint line. And from here, I'm going to take my right side hand and I'm going to stabilize the distal femur just like so. And I'm also having my hand on the patient's foot. I'm going to sit my butt back until I get a medial glide of the lower leg. And then from here, I'm going to flex the knee until I get to the point of resistance and then pop right back up again. And the idea behind Mulligan exercises, or Mulligan mobilization with movement, is that we're trying to improve pain-free range of motion. So we don't want to blow through a bunch of pain here. Essentially, I apply the mobilization and I try to go to the patient's threshold where it starts to hurt, then back off again, then go again, and back off. And the idea is I want to slowly improve that range of motion of course time. Tibiofemoral mobilization with movement with a lateral glide. So same setup as a medial glide. Basically I have my patient prone, knee is going to be flexed to 90. From here I have my mobilization belt around my hips, around the patient's lower leg as close as we can get to the knee joint but still in the tibia. From here I'm going to take my right side hand, I'm going to stabilize the distal femur. From here I'm going to sit my butt back to apply my lateral glide, and from here I just go to the point of resistance into flexion, back off, go to the point of resistance and back off, with the idea is that we're not provoking the patient's pain, and we're slowly improving range of motion over the course of time. Tibiofemoral posterior glide, Mulligan mobilization with movement. What a mouthful. So essentially, I have my patient lay on their back, bend their knee to 90. I'm going to take my fingers, interlock them together. The palm of my hand is going to be on the patient's tibial tuberosity just like so, right? And then from here, other side hand is going to interlock my fingers. What I'm trying to do is posterior glide the tibia. So I'm taking my hand and trying to posterior glide the tibia just like so. Now, underneath of Johnny's foot is a towel, so his foot slides really easily. And he also has a belt in his hand that's attached around his lower leg. So when I apply this posterior glide just like so, I'm going to ask Johnny to go ahead and flex his knee. So pull on that belt, yep, bend that knee a little bit, and then go ahead and kick out. And I relax my tension, and I put my tension back in, and go ahead and flex that knee, Johnny, back and forth. Let's kick out one more time. I'm gonna push, give him some tension, and go ahead and slide up as far as you feel like you're able to, comfortably, and relax. Tibiofemoral internal rotation mobilization with movement. So essentially I have my patient here, Johnny. He's going to be putting the majority of his weight on his backside leg, and his front side leg doesn't have a bunch of weight on it. We also have the backside of the chair, so as he lunges forward, he doesn't have to put a bunch of weight into his knee. If you're doing this with a patient that has knee osteoarthritis and they're very painful, this might not feel great. So if we can, we want to offload the front side leg and put most of the weight either on the backside leg or through the patient's hands, right? From here, we have the tibial tuberosity sitting right in front of me. I'm going to take my thumbs, I'm going to put them on top of one another, and I'm going to have them right over top the tibial tuberosity. From here, I'm gonna take my hand and wrap it around in the popliteal space. I'm actually grabbing the back side of the fibular head. And then from the other side, I'm gonna do the same thing into the popliteal space, right? And from here, I'm gonna have Johnny do a little bit of a lunge towards me, and I'm gonna rotate the tibia internally. Yep, and come right back again. So essentially what I'm doing is I'm pulling with my outside hand towards me, and the other side hand I'm pushing. So I'm rotating or I'm twisting the joint. Let's do a few more of these so people can see. So essentially, go ahead and just bend that knee, and I'm gonna pull you into some internal rotation. Go ahead again, internal rotation, back off, and one more, internal rotation, just like so. So which mobilization do you want to use with your patient? Essentially, we're trying to use the one that feels the best and improves range of motion the most. In terms of frequency or how often should we be doing these, how many sets, how many reps, the authors use 3 sets of 10 reps, and they perform this 3 times a week for 2 weeks. Next, we'll go over some Maitland mobilizations. The first is going to be a posterior mobilization of the tibiofemoral joint, or pressures on the tibia. The idea behind this is we're trying to improve flexion range of motion. Essentially, we have Johnny laying on his back. I have a half foam roller behind his thigh. It's important that the half foam roller is going to be above the joint line. And from here, there's a variety of ways to perform this technique. Classically, you take your thumbs on the tibial tuberosity, fingers gonna wrap around to the popliteal space. We're trying to impart a posterior glide just like so, right? In my opinion, this is a little tough on the thumbs. So what I do is I use the web space in my hand, just like so. I have the web space in my hand, right over here on top of the tibial tuberosity. I can even lock out my elbow if I want to get some good pressure. And I can drive straight posteriorly, just like so. We can also do the posterior mobilization of the tibia with the patient in more knee flexion. And this is what I tend to use a little bit more so. I would say the first variation is more with patients in a lot of pain. This is going to be probably a little bit more effective because we're actually going to the position we want to mobilize in. So essentially, you want to go about as far as the patient is able to handle. And then from here, what I'm trying to do is use the web space in my hand again. I'm going to go on the tib tuberosity. I want to push along the plane of the joint. So if I'm pushing straight this way, that's not how the joint moves. The joint moves this way, right? So I'm trying to posteriorly translate. I want to be on the same plane as the joint. And then from here, I posteriorly translate the tibia just like so. Next, we'll go over some anterior mobilizations of the tibia on the femur. The goal is to improve extension range of motion. So we'll start off in about 90 degrees of knee flexion. From here, this is basically an anterior drawer test. I'm going to take my butt and sit on the patient's foot just like so. From here, my thumbs are going to go on the tibial tuberosity. My fingers are going to go in the popliteal space behind the knee. And then from here, I'm going to impart anterior force just like so. And the idea is I want to pull along the joint line. So I'm not pulling directly at me. I'm actually pulling up this way. So again, fingers are going to be behind the knee, thumbs, tibial tuberosity, and pulling along the plane of the joint, just like so. We can also do our anterior tibial mobilizations in a prone position. So essentially, Johnny is on his belly. He's come off the edge of the table so that his kneecap is no longer on the table. Okay, that's important because you don't want to grind the patient's kneecap into the table. And from here, I'm going to grab the patient's lower leg. I'm going to go into a little bit of flexion, but if the patient can go fully into extension, that's also fine. And from here, I'm going to find the joint line, opposite hand, I'm going to go just below it. And I'm going to apply an anterior force. So essentially, I'm going straight down towards the floor while I stabilize the patient at the ankle, just like so. Now this one I basically just made up, so it's just important that you know that. But it does follow, this technique does follow the joint arthrokinematic rule that we talked about previously. So essentially, if I have a patient that's really painful and it hurts to fully extend their knee, I may actually take a towel, put it underneath of their calf, just like so. I find their kneecap, I'm gonna take the web space in my hand, I'm gonna place it right above the kneecap. What I'm trying to do is impart a posterior force on the femur, and what should be happening is that the leg is going to press into the towel is gonna impart an anterior translation on the tibia. So this is a nice way to improve extension range of motion that I use a lot, but it's important to know that I just basically made it up and I didn't grab it from a research study. So. And if you're a big fan of made-up manual therapy techniques, you should like this video and subscribe to the channel for more. Patellofemoral mobilizations. Essentially, if I am mobilizing the patella inferiorly or down towards the feet, that's theorized to help with knee flexion. If I'm mobilizing the patella superiorly towards the patient's head, that's supposed to help with knee extension. So you can choose which direction you'd like. Now, there's a variety of ways to do this. Classically, it's described as trying to take your patient's patella and putting it within the web space of your hand, just like so. And then from here, take my other side hand, web space, and go right underneath the patella. And from here, I can either go superiorly up, I can go inferiorly, or I can essentially go back and forth. Now, personally, I don't like this technique because I feel like I don't have a great grip on the patella. I'd rather use my fingers, so essentially my index finger and my thumb, just like so, grabbing the top of the patella, and I take my index finger and my thumb on the other side, grab the bottom part of the patella, and from here, I feel like I can very easily mobilize superiorly or inferiorly, either direction that you want. So how about intensity, sets, reps, so on and so forth? Now this is obviously going to change based on the study, but generally speaking, you're looking for a grade of 2 to 3. You want to perform about 2 to 3 oscillations every second and perform this for 1 to 2 minutes per glide. So in many of these studies, they combine manual therapies with manual joint range of motion, as well as stretching for the quadriceps and the hamstrings. So after you do some of your mobilizations, probably good to follow up with whatever joint range of motion technique you like. Follow that up with some quad stretching, some hamstring stretching, whatever you'd like. Probably gonna add some benefit to your program. All right, what's also important to say is that in several of these studies, not only did they mobilize the knee joint, but they also mobilized the hip joint. And we have a video for you. It's gonna be right over top of my head right here. We go over my favorite evidence-based mobilizations for the hip. You can add that to your patient's program when they have knee pain too. Click on that link,